and welcome to the Road to Genome podcast. This episode is being brought to you from Genomics England's headquarters in central London. I'm your host, Helen Bethel, Genetic Counsellor and Workforce Development and Education Lead for the North Eastern Yorkshire Genomic Medicine Service. I'm delighted to be joined today by Amanda Pichini, Clinical Director for Genomics England. Hi, Amanda.
Hello.
Hi. So, you're Clinical Director for Genomics England. So,
Yes.
Can we start by asking you what that means?
Certainly. And thanks for having me on the podcast. So as Clinical Director at Genomics England, that means I'm responsible for kind of giving strategic clinical leadership to our different services and programs.
Mm-hmm.
We do a lot of different things at Genomics England, including genomic sequencing, whole genome sequencing for patients with cancers and rare diseases in the NHS Genomic Medicine Service. And as part of that, we hold consented participants' genome and health data in our research environment, the National Genomic Research Library. So in order to make sure we can do that safely and appropriately and thinking about the NHS clinicians and patients' journey in mind, my role is to help make sure that all of the sort of products and services that we do can sort of consider the clinical implications of the endpoints of that. A big part of my role is also focused on the Generation study, which is a large research study involving sequencing the genomes of newborn babies to screen for a larger number of rare conditions and explore the sort of wider research and lifetime potential of having that genome. So a lot of that requires also that clinical input and expertise to think about what that whole journey looks like, from recruitment to consent to feeding back results. So really it's trying to make sure that we've got all of those considerations in mind so that what we do is kind of safe and considering the kind of health needs of our participants and for the NHS.
Great. And we'll obviously get to your journey in a moment of how you got there, but knowing you as a genetic counsellor, it's amazing to know that there's a genetic counsellor in that position and being able to give that clinical direction, like you say.
Definitely, yeah. And it's great because Genomics England actually has always had a role for genetic counsellors since it started, which I think is a testament to really appreciating the value that our genetic counselling skill set can bring to genomic healthcare, right? And we are Genomics England. And so we really, I think it's important that we make sure that those of us that have that specific training and experience in understanding the impact that genetics and genomics can have on people's health and their wider life and their family's life is really at the heart of what we do here. So being able to take my clinical background and experience and passion for genomics and genetic counselling into what we do at Genomics England is something I'm really grateful for.
Yeah. So thinking about when you were a child, is this what you always aspired to do?
Probably not when I was a child, no. I think that, it's maybe more the case now where people might hear about genetic counselling as a relatively more common career option earlier on in their life. But for me, there's probably a variety of things that I maybe wanted to do as a kid. I was always pretty academic, but it wasn't till I got to university and was studying science and just happened to come across the term genetic counselling when I was trying to Google options for research placements that I could do to gain experience as a summer job. Came across genetic counselling as a term, had never heard of it. But as soon as I started to learn about what it was, like I think is similar to your story, I was just completely captivated by it. And I thought, this is exactly the kind of thing it sounds like I want to do. I can take the interesting bits about science, the cutting edge bits about genetics in science, and the kind of personal communication piece where I can talk to people and find out about their stories and their journeys and the hard decisions they're making. So that just then led me on a fairly mundane, I guess, track of gaining experience sort of volunteering for helplines in the town where I went to university. So getting experience talking to people who are going through kind of difficult health problems, mental health problems in their life, shadowing in a genetics clinic in London, Ontario, where I went to school. And that really helped just kind of solidify that this was something that I wanted to do. So not something that child Amanda wanted, but that young adult Amanda wanted, and I haven't really looked looked back since.
Fantastic. And does it run in the family? Do any of your family work in healthcare settings, or is it quite different?
No, not really. I do have some family members that have kind of gone down the kind of science business route, that kind of thing. My dad worked for pharmaceutical companies for a while, and in other sort of healthcare companies in the kind of business sales side. But this was something that I just had always had an interest in, and didn't necessarily have the passion to be a doctor that I think one would really require if they wanted to go down the medicine route. So I was really looking for other opportunities. And I think when you're in high school and have an interest in science, sometimes the options presented to you can be quite limited. Yes. Genetic counselling isn't necessarily the first thing that people put forward, right? So it was something that I kind of came across myself. And it's great to see now that it's become a much more generally well-known and popular career option, which also makes it very competitive for those interested now to get a training placement.
And so thinking about your kind of, when you then achieved your role as a genetic counsellor, what was your journey like between that and your current role?
That was more meandering, I would say. So I was very clear and on my direction to be a genetic counsellor. But once I got my sort of qualifications and I did my training at the University of Toronto in Canada, I wasn't quite sure where I wanted to take the role, and wanted to gain some experience working in a variety of different places. So my first role actually was a role that's quite unique for the UK, but more common in North America, where I worked mostly as a lab-based genetic counsellor. So in the genetics lab at the Hospital for Sick Children in Toronto, helping to interpret the results of the genomic tests that we did at that time, writing up reports and helping to guide clinicians through how they might order the right tests and return those results. So it's a role that's often taken up in the UK by registered clinical scientists, but that role can often be include people from genetic counselling background. And that was really helpful because that gave me some experience in the more variant interpretation. What does it mean to sort of explain what a genomic sequencing result means, and in a way that's going to be understandable to the clinician that requested it and then the patient at the end of that report. So that was really interesting. And then I moved to the UK and worked in the Bristol Clinical Genetics Service for about 7 years. And throughout that kind of had a range of different secondments, which was really helpful so I could experience a lot of different things. I consented to the Deciphering Developmental Disorders, the DDD project, which was a really groundbreaking project at that time, trying to find new diagnoses for children with developmental conditions with the cutting edge genetic and genomic tests that were just then available. And that then kind of led me into the 100,000 Genomes Project when Genomics England was first established, which was then saying, right, whole genome sequencing is now the cutting edge technology that we think could be used to help find genetic diagnoses for patients with rare disease where we haven't found one before. Or for people with cancer where we can understand more about their cancer. And that was really fascinating to me. So I joined our regional team and was involved in helping to set up the recruitment pathways, training healthcare professionals to consent and give results. So that really took me down a course of, I guess, being quite passionate about mainstreaming. I didn't necessarily want to specialize in one area of genetics like cancer, cardiology, or prenatal, but felt like I was too interested in all of it. So the idea of being able to help make other clinicians and healthcare professionals comfortable to bring the genetic tests that were relevant to their specialty into their service and make that more accessible to patients in a safe way, kind of imparting a lot of the skills that genetic counselors and other genetic specialists to us is our bread and butter, but we need to make sure that some of that is accessible to other healthcare professionals too. So that's, I think, what really drove me through the 100,000 Genomes Project.
While still keeping really close to that science.
Exactly.
That's what
exactly. Yeah. So we were able to say, right, this is what's new and up and coming now, which is exciting, but also has its caveats and limitations and important things to make sure we're managing patients' expectations about effectively. So that made it a really interesting challenge, regardless of what specialty you were in. So yeah, I spent some time also working with the Genomics Education Program, which is now part of NHS England, and they're a fantastic genetic team who really have that responsibility of helping to educate the workforce on genomics, which is no small ask.
Yeah.
But we were able to focus on developing some resources and competence frameworks that hopefully can continue to be used to give other healthcare professionals an entry point, depending on what their knowledge level is like in genomics, and helping them to think about how they can get to a place where they can start to consent and return results for genomic tests for their patients.
Yeah.
So all of those experiences culminated in me then joining Genomics England around the time when we were starting to develop the newborn genomes program, linked to now running the generation study as a research study. And since then, I've been here for 3 years, initially as our clinical lead for genetic counselling, and now as clinical director, which hopefully gives me even more of an opportunity to feed into the work that we do and have more of a kind of downstream and upstream impact on how we kind of mainstream genomics into healthcare and research.
Yeah. And how does your kind of now national role compare with the kind of clinical role that you previously did?
That's an interesting one, actually, because I think many genetic counsellors, I would argue, probably go into the profession with a real interest in that clinical
element.
Yeah, absolutely. And having that kind of one-to-one or family-focused relationship with the person in front of you and really getting into the detail of the difficult decision or information that you're wanting to give to them is so important. And that's absolutely what drove me into the profession as well. And I knew when I left that kind of role that I would miss it and probably would always miss it by default. So I kind of accepted that. But since being in this role, personally, I think I can still really see how the work that I can do, and I can use my genetic counselling skills to have a wider impact on the patient's experience, whether that's through the kind of services and processes and materials that we're developing, or the training that we can impart, the engagement that we're doing with other healthcare professionals. I can see how that leads to ultimately kind of helping to improve patients and participants' understanding of genomics and thinking about how that's affecting them and their family's life. So that brings me, I guess, that fulfillment in the role. And I think as well, I think it's really important that for genetic counselling in the profession, we give ourselves the opportunity to see how we can use our skills in a wide range of roles. That clinical roles are hugely important and hugely valuable. And if that's what drives you and that's your passion, that's what genetic counsellors should do. But for others who want to take their career in a slightly different direction immediately or at another point in time, to know that there are other options that we can use our skills for, whether that's research or policy or education and training like your role is doing, that there's just so many different ways that we could apply our skills to have a wide impact. And it's just important that we do what we can to follow what our passion is and seek out those opportunities when they might be possible. Yeah.
And I think, genetic counsellors have such a unique skill set that I see echoed the sentiment of what you're saying, is that there's so many roles that I now see and they just absolutely are based on that skill set of genetic counsellors. And there's so many different roles now, isn't there, than, like you say, that traditional role of being patient facing. I hear you with that. So just thinking about your clinical work, is there a case that's maybe stayed with you that you kind of maybe draw on that kind of motivates you in the work that you do now? Or
I wouldn't say there's one in particular that has kind of carried me through. But in general, I guess one of the areas that really interested me and that I found quite challenging, and it was what I focused my research project on when I did my master's in genetic counselling, was focusing on the adolescent population. So for a while, I was a genetic counsellor in a clinic that specialised in individuals that had Turner syndrome, and also another clinic that specialised in giving like multidisciplinary care to people with 22q deletion syndrome. And these are kind of lifelong conditions, but they do have quite unique implications for people around adolescence, as many genetic conditions do. You might have had experience talking to parents in the early stages, supporting them through their child's diagnosis and what that would mean. But suddenly you have people who are coming to that age of adolescence, gaining their own autonomy, capacity, understanding about what that condition means for them, asking their own questions, starting to think about, even if that's still some years in the future, what that means for their future family options, relationships, etc., whilst at the same time going through the usual challenges of adolescence, which we all remember aren't easy. And I think that provided a really kind of really challenging area for genetic counselors to have to work with. So I found a number of challenges myself that way, a general lack of resources and materials that really spoke to the adolescent person, as opposed to here's a leaflet because you've just been diagnosed with X as an adult, or here's a leaflet because your child has just been diagnosed with X. So a lot of the experiences that often stick in my mind have to do with that kind of time period and understanding more about what the unique needs of adolescents are. I think there can often be a hesitation for many genetic counselors and healthcare professionals to know how to relate and speak to people in that age group. That can be a real challenge. And it's something that I think about again now in relation to the generation study, because although we are recruiting parents and participants are newborn babies, we might think that, 10, 16 years is still a ways off, but it's really important that we're keeping in mind what that sort of growing autonomy exactly will be for those newborns as they get older and come to understand what it means to be part of a study like this and how they can then make their own choices about whether that's something they want to continue to be part of, what research may be taking place with their data, how they feel about that. And that can also change as society changes in the future. So it's an area that I think is really interesting and one that will continue, I think, to be one that we'll have to explore here for sure.
Yeah, absolutely. So you've mentioned the Generation Study a couple of times. Can you tell us more about it?
Yes, of course. So the Generation Study is a large national research study, and our aim is to really understand more about the impact of genome sequencing in newborns. And with that broad aim, we kind of have three areas that it's really exploring. The first one, and the one that we probably talk about the most, is using genome sequencing to help look for a larger number of rare conditions in a screening context. So in the UK, currently every baby is offered newborn screening, sometimes called the heel prick test, around a day 5 or so of life, taking a small spot of blood that looks for around 9 rare but serious conditions that the UK National Screening Committee have approved. These are conditions that we have really, extensive evidence about in terms of being able to pick them up early and that we can intervene early, and that can really improve those babies' lives. Also know that in many other countries, they screen for a larger number of conditions than 9. And there's been a lot of calls from rare disease patient organizations to think about how we can expand newborn screening so that we can make diagnoses and intervene earlier, because that's often a big challenge for families. And I don't know if you've had this experience as well, but I can certainly think of times when I've had families in my clinic who, in the process of waiting for a diagnosis, by the time that might be made, sometimes that means they've missed out on an opportunity for a treatment or an intervention, or they can still have that intervention, but it would have had an even greater impact if it was done sooner. Or they're wanting to have another child, or they've had another child, and without that diagnosis made earlier, they didn't have that information to help inform those decisions. So that importance of early diagnosis is really so key. Now, genome sequencing isn't the only way to expand newborn screening. There's lots of different technologies we could use, but the aim of our study is to look at genome sequencing as the technology, because with that one test, you could potentially look for hundreds of conditions that could have that early intervention. So that's a kind of key aim. But parents consenting on behalf of their children would also be agreeing to their genome and health data being added to our research library, where it's de-identified and could be accessed by approved researchers who are doing research around genomics and health. And we think that in combination is really important because, for one, we need to have that long-term data available so we can understand whether this screening was actually helpful. Did we get some false positives through testing? Did we get some false negatives, cases that we missed because we want to be really careful about the results that we're returning and feeding back? So we might find that there are some children that develop conditions or other conditions as they get older, and only through having that long-term genomic and health data can we get a good understanding about whether that happened and how well our kind of study worked. But also being able to have access to research in a safe way means that we can potentially find out more about interventions for conditions that we don't currently have treatments for, understand more about the causes of rare conditions in health and how genetics impacts our health in general. And having that data gives us a real opportunity to do that. So that's another thing that's really important for us to explore in the generation study.
And almost self-feeds that first arm, doesn't it? That kind of drives that knowledge of the conditions that we don't yet know of, but we know exist, but just haven't found the basis of yet. So it kind of self-feeds that process, doesn't it, of that first arm of those conditions that we currently test for. It's keeping a mindful eye on what is also out there that, you know, in 10 years' time should be added to that list of conditions.
Absolutely. Yes, that's right. And the other thing about having that data in the long term means that we have the opportunity to at least explore with the public and with our participants what the kind of lifetime potential of having that genome sequence is. So in the study, we'll be sequencing babies' genomes shortly after birth and then looking for a select number of just over 200 conditions that we've gone through a kind of extensive engagement process with the NHS and with patient organizations and the public to kind of work out what that would be. And that's kind of done at that very early stage. But we also want to understand, are there other opportunities where it could be useful to ask other questions of the genome to either look for other conditions or other pharmacogenomic information that might inform how people respond to drugs that could be helpful to them at future stages in their life. So whilst we're not currently actively doing any of those additional things, we want to be able to explore that so that it can help us inform some of those future questions that we think would be really important to answer.
Yeah. So with the data that you're collecting in that research library, so there's a lot of conversation that's going on nationally at the minute about and internationally about the diversity of data sets. So is there a mindful eye on that within the generation study of that kind of equity and diversity of the data that we're collecting?
Definitely. I think there's probably two elements to that. One is, so when we talk about diversity of data sets in genomics, we're often referring specifically to ancestry. So we know that amongst genomic data sets, the majority of that data is made up of patients or research participants of Northern European ancestry. And that means that we might have a lot of knowledge about the genetic variation that exists in those populations, but relatively less about other populations in different ancestries. And that means that then that could hinder our ability to make more diagnoses in individuals of those ancestries, depending on the test and depending on the context. So by adding to that diversity of ancestry in that genomic data, that should be able to help all of us get better in making diagnoses and understanding more about how genetic variation impacts our health. And that's really important. From the generation study point of view, we also want to make sure that we're providing as equitable access as possible to participating in the study. And that goes beyond just ancestry. So we want to make sure that participants or parents who have come from varying socioeconomic backgrounds, who come from urban and rural areas, different geographical areas across the country, who might have different learning needs, a range of different characteristics. We want to make sure that our materials and our processes can really enable as many people as possible to be able to participate in the study from a range of different backgrounds and beliefs. So that's something that we've taken great care of to do as we've developed the materials for the study. And one thing that I'm particularly proud of that we've done is embed user research from the beginning, meaning we've had the opportunity to interview parents, midwives, other healthcare professionals, parents who have just given birth or who are pregnant at the moment, and ask them and understand their experiences. And we've taken care to make sure that they've come from a range of backgrounds so that we're really building that into how we've designed the study so that we can think about how those study teams who are facilitating consent for those parents can make sure that they can provide whatever those parents might need, whether that's interpreters, easy read information that we've tried to make as readable as possible, and other supports that might be in place so that people feel like they can have what they need to make an informed decision to take part in the study.
That's fantastic. And, we've heard through the various podcast guests that we've had just how important and how pivotal it is to have that patient voice at the centre of it. But it's great to hear that you're also bringing that professional voice in as well. So the people that are actually going to be delivering this can help kind of shape and form it. Yeah. So I'm thinking about the Generation Study, where it's up to now. How is the Generation Study going then?
We're in the early stages of recruiting participants to the study, which is really exciting because we're able to take all the work we've done to design and engage and develop the study over the last 2 to 3 years and see what that looks like in action. So a small number of trusts are recruiting participants to the study. We are hoping over the coming months to rapidly increase the number of trusts that are also offering the study to participants. And that usually happens in an antenatal kind of maternity setting in hospitals where mums and parents are being approached during pregnancy by their study teams about whether they can take part. We anticipate that around 1% of all families will have one of those 200 or so rare conditions we're looking for, because each of them are so individually rare. When that does happen, we've been doing a lot of work, again, working with patient organizations, the NHS specialist clinicians and genomic medicine service alliances to develop a network of professionals that can be involved in hopefully rapidly returning those results to the right pediatric team so that the family can be informed, be brought into the right place for follow-up tests, because our results aren't a diagnosis. There'll need to be other tests done as it's a screening result to confirm if that condition is present or not, and be able to provide access to additional study-funded genetic counselling, which I think is really important because in any situation, even if there is an intervention that can be provided, which is great for the family, this is still going to be hugely impactful news for that family when they hear about a potential condition in their child that they more than likely won't be expecting. So we've been really trying to do a lot of work in advance of that happening in reality to prepare as much as possible for what that situation would look like. So yeah, the hope is that over the next few months, we can really continue to learn from the experiences of sites in how they're finding recruitment is going, how the materials are being used. Are there changes we need to make? Is there broader engagement we can do with different communities so that that equitable access to participation is something we really see bearing out in reality? And as we start to return more results, that we're seeing what the impact is on the NHS and on those families, because we want to make sure we can carefully evaluate that so that at the end of the study, we have as much information as possible to provide to those decision makers like the National Screening Committee, the NHS, the Department of Health, to think about whether and if genomic sequencing has a role in newborn screening in the future.
And thinking about kind of the genetic counselling profession, how do you think the Generation Study will impact the profession going forward?
My hope is that we can really see the Generation Study as one of many opportunities that the genetic counselling profession can embrace and grow into. I think genetic counsellors and genetics professionals in general have always been at the cutting edge of what's next in genetics and genomics. We talk a lot about mainstreaming now, and that I think is really involving us, again, imparting the skills that we have so much experience with on a range of other healthcare professionals so they can offer genetic tests to their patients. But there will always be a really new and complex end of what genetics and genomic technology is doing, with difficult questions, complexities around returning results, difficult ethical questions that we need to be able to navigate. And I think that's where the genetic counselling role and genetic counselling skills can really continue to grow into. There's other areas where that can happen as well. There's some great work in North America, for example, about embedding genetic counsellors in primary care so that they can be at the forefront of some of the other technologies that might be coming up more in practice, like pharmacogenomics or polygenic risk scores. So this is another example where, although a lot of the management for families will be with pediatric specialist teams, there's going to be a lot of questions that I think families will have about, what does this result mean for me and my child? Maybe my child doesn't have any symptoms yet, so it's even more challenging for me to think about what that result means for them and their future, for my other children, for my wider family. Understanding what that treatment or intervention could do to improve things, and all the uncertainties around that. There will be a lot that we can't predict based on these results. That's partly what we want to hopefully learn more about through research. But to help address those uncertainties and questions, I think that's a huge area where not just the genetics expertise, but the psychosocial expertise that genetic counselors can have can really help provide to families. So that's one reason why we've provided funding through the Genomic Medicine Service Alliances to make sure that we could embed genetic counselling access in different ways to support participants getting those results through the Generation study. And hopefully throughout the study, we can see where the real value of genetic counselling, as well as other healthcare professionals, lies in that whole result return process, so that we can think about what that could look like if a future world involved embedding this more extensively as part of a clinical service and getting sort of genetic counsellors and other healthcare professionals prepared for what that could look like.
Yeah. So at the moment in your role, what does a good day look like for you? What's the most rewarding bit of your work?
Every day is so different, which is why I pause, because it's a real, I think a good day to me really comes when we get some of that sometimes anecdotal feedback through our team or from sites directly about some things that have been working really well. So, and that's not always going to happen. It's great that we hear about things to improve too. But when we hear about a study team who's really felt like they had maybe a difficult experience with a participant, difficult questions they asked, but they felt like they were able to work that through and help them to reach a decision, that is music to my ears to hear.
Especially when you took it from concept to delivery.
Exactly. Absolutely. And I mentioned we're not yet at the stage where we've seen the return of many results, but I can see a really good day looking to me like when we know that we've gone end to end and we've returned a result safely and as rapidly as possible. I don't think we can always expect, like we often see in genetic counselling, that our patients will be really happy about the information they're hearing, because we're often talking about some difficult things and some challenging things. But knowing that we've, through the processes we've developed, provided as much support in a timely manner as we could, that to me would be a really great day when that happens.
Exactly. It's providing that cushioning, isn't it? It's, kind of, they will be on that pathway, and it's about the journey, isn't it? It's not the end-to-end points, it's the journey that they make between. And as you say, as genetic counsellors, we often hear those journeys and those stories from patients that have been on a difficult diagnostic journey and maybe haven't been able to access the support. So this is where, it's incredible to sit here and listen how much of that genetic counselling you are bringing to the study, and that kind of, that cushioning, I guess, that you're putting there for patients. So on the flip side, Amanda, then what would be a challenging day for you?
I guess, to try and deliver an end-to-end service research study at a national scale in a national health service is a huge ask. Absolutely. And so we naturally expect to get critique and questions and concerns from, let's say, from NHS healthcare professionals about, how on earth am I going to deliver this or incorporate this into my day-to-day role? Or maybe I can see how that looks now as a research study, but how on earth are we going to do this in the future? And sometimes those conversations can be really challenging because a lot of these are questions that we don't necessarily know yet ourselves. So I'd say those can be sort of tough things to work through. But again, I think hopefully my experience and that genetic counselling skill set that is used to dealing with uncertainties and unknowns about the future is what I try and bring in there, where if there's things that we don't know about yet, we have to be honest and transparent about that. If there are things that we can do to help support healthcare professionals or participants' experience, then we'll do as best as we can to be able to do that and learn from that. And that's how we've been, I think, trying to deal with challenges so far. And I'd love to, say in 2 or 5 or 10 years' time, be in a position where at the very least, our experience delivering the study has helped raise awareness of genomics in the maternity journey, the pediatric journey, the screening journey, so that when a midwife is coming across a person with a family history of a particular condition or is consenting, to the heel prick test, that they have some of that knowledge about how genetics and genomics can impact that person's healthcare journey because they were part of the generation study or they heard a talk or went to an event about the generation study. So if we're at least able to use this study and the wider work that we do at Genomics England to help raise the profile of genomics as a technology that is already impacting patient care, then that's a win. And that at least means that we can be more aware and surface the challenges that people have, the questions that people have about how they're going to incorporate that into their practice. And we can deal with that as and when that comes, like we do with any new technology that has big questions for healthcare and wider ethical questions for society. So yeah, I think days can definitely be challenging, but I think we're really fortunate to work with an excellent team here that come from a range of mostly non-clinical backgrounds, but a range of backgrounds and expertise, and be able to work with the Genomic Medicine Service alliances and trusts that have also brought their own enthusiasm about how they can deliver the study and work with us. So that's really great.
Yeah. So looking to the future then, what do you think is the most exciting thing that is coming down the tracks, would you say?
I think there's a lot of room for genomics to grow, I guess. Yeah. And we've seen a lot of that already. We've seen how it's kind of, revolutionized rare disease and cancer diagnostics. We're now trying to see about what that looks like for screening. I think there's a lot more in the future that we could continue to explore about what genomics can contribute to sort of preventative healthcare in general. And we can see that as like an ideal healthcare service, right? Rather than reacting to people who become ill and approach with a need, we can kind of preempt that with knowledge that we have before someone gets ill, whether that means then we're imparting information that's useful in itself, or we can provide access to treatment before at early stages of symptoms in a more timely manner. That would be a great ideal. So that I think is what we can look forward to the future. And that is an exciting concept, but I also can't forget all of the challenges that come with that along the way. And that doesn't mean we shouldn't explore it. If we have the opportunity to explore it, I think it's so important that we do. But doing that whilst we can engage extensively with the public, because societal questions change over time, with the people with rare disease and cancer and those conditions who have had those experiences and can tell us what they're dealing with the NHS services who are dealing with these questions and concerns on the ground, so that we can acknowledge the uncertainties there, help manage the expectations about what we can and can't do now versus what we can learn and maybe do in the future. I think that's really important, because it's easy to jump to that conclusion that if we have our DNA, why can't we just predict everything and act on that? And there's lots of limitations we still have about our knowledge of genetic conditions and how we can treat them. So again, hopefully that research can continuously help us to do that. And alongside that, if we're continuing to have that dialogue about those tricky questions and making sure that there's support available as much as possible when we need it, then I think we can get there.
Yeah. So what drives you?
I think what drives me, going back to your earlier question about what is a good day for me, and going back to why I was so passionate about genetic counselling to begin with, what drives me is seeing people and families gain information about genetics and their health, which may have been a question that they've been exploring for a while. And bringing that information into their life in a way that they can assimilate it, adapt to it, hopefully make positive change, even if that's quite difficult. So whether that's on an individual patient level, like we might do in a clinical setting, or at a broader, more policy level where we can hopefully enable research and transformational studies and genomics in clinical care that can do that. That is one key thing I think that really drives me. The secondary aspect to that, because of having had that experience educating healthcare professionals, is seeing those healthcare professionals where that penny drops and they have that first moment where they understand why that genetic or genomic test or study that we're doing is helpful, and they can really see how that impacts their patients. And that drives me, because then I feel confident that when they encounter patients in a similar situation, they'll feel empowered to explain what the benefits and the limitations and the opportunities are with that particular genomic test or study.
Yeah.
And that's really powerful, because then that the knowledge of genomics is not just kept with genetic specialists, but it can be passed out to so many other people.
Yeah.
That can then be at the end point with patients and families having those conversations.
Yeah.
So being in a role where we have the opportunity to do that, that's what drives me.
It sounds very much like it's the inner genetic counsellor that's driving you when I listen to the answer, because it is so key, I think, to what many genetic counsellors would answer. So it's lovely to hear. Exactly. So then, last question then, where do you think your ambition will take you from here?
Gosh, that's a very difficult one to answer, because if I was speaking to the Amanda that had just graduated as a genetic counsellor, I don't think she would have said that she would be doing this role.
No. Yeah.
And I'm not sure this role might have even existed at that time. Yeah. So I don't know, but I do think that I will continue to probably be driven to want to do roles that can influence policy and NHS service and practice at kind of a broader level, that can help take some of the newer technologies in genomics, the newer contexts that it can be used in, that can be quite difficult, and want to get stuck into it. And another great thing about this role has been the opportunity to also lead people in teams of, again, people of different backgrounds, and help our kind of colleagues at Genomics England understand what the NHS and patient experience looks like, so that we can develop better information, think about how we can design programs and services in a way that is working really closely with the NHS, and bringing our colleagues along with us so that we can do that in the best way possible. And I've really enjoyed that. So whatever that specific of that role looks like, I think it will encompass all of those things, I hope. And I don't think there'll be any shortage of those opportunities, which is brilliant in when you work in the genomics world, because I think there's just so much potential there that there will always be a number of opportunities available, depending on what people's interests are.
Yeah. Fantastic. It's been absolutely amazing to speak to you, Amanda. It really has, and hear about all your passion and really bringing that genetic counselling element to the work that you're doing. It's been great to talk to you.
Thank you. It's been great to talk to you as well.
Thanks for joining us today. If you would like more information about the topics that we have discussed, then you can find these at our website, www.ney-genomics.org/podcasts, where you'll also find all the episodes in our podcast series. These can also be found on Spotify, Apple Podcasts, and all other podcast platforms.